Hey, this is Matt Hartman from Pittsburgh, PA. Welcome to the RadPath lecture series. I think you're going to like this one. This is very straightforward. We're going to be talking about testicular pathology. Again, the entire lecture can be found on the ACR Building Blocks site. And if you're interested in Anki RadPath flashcards, check out the About section on our YouTube channel. So this presentation is based on a radiographics publication from several years ago. And I encourage everyone to take a look at the radiographics publication. Some great RadPath. So, the testicle, how do we study it? Well, we have to remember the embryology, that it comes from the lumbar region and migrates into the scrotum, usually successfully. And if you get an undescended testes, that's a pediatric diagnosis, cryptorchidism, that can be a big deal. We'll talk a little bit about that. Remembering the testicles are superficial organs, so this will be best imaged with a high-frequency ultrasound probe, no radiation. The testicular architecture should be homogeneous, and we can confirm Doppler flow by using the Doppler settings on our ultrasound. Again, we want to have some Doppler flow to the testes. We'll talk about that, what it means if you have too much or too little flow to the testicle. So let's start with a normal testicle. On ultrasound, nice and homogeneous, a little bit of flow. Again, we don't want, it's sort of like the Goldilocks. We don't want too much, we don't want too little, just the right amount. So when you have testicular pathology, it can be non-neoplastic, neoplastic, ischemic, infectious or inflammatory, or post-traumatic. Again, these are big categories for pathology in any organ system. So a typical scenario is a patient comes in with a scrotal lump, and we are going to use ultrasound. And a couple of questions we want to ask ourselves. Number one, is there a lesion? If there is it intratesticular or extratesticular? Extratesticular lesions are often benign, whereas intratesticular lesions are often malignant. So again, extratesticular good, intratesticular bad. Going back to our basic RadPath lecture, anytime you have a lesion, answering is it solid or cystic? A solid intratesticular lesion is worrisome. Again, another intra-RadPath question, single or multiple? If it's multiple, think Mets or lymphoma. Okay, let's put this to work. So a patient comes in with a lump in the scrotum. We see a lesion. Is it solid or cystic? Well, remembering our basic RadPath, this is anechoic. There's some positive through transmission. This is cystic. This is the testicle up here. This is superior. This is extratesticular in the epididymis. We just diagnosed the epididymal cyst, benign. Here's another lesion. Got a nice testicle, nice and homogeneous, except for this anechoic component. This looks like a cyst. And the good thing is we put Doppler flow, there's no Doppler flow. This potentially could be a blood vessel, but because we put blood flow on there, we know it's not a blood vessel. Anytime you see a lesion, put blood flow on it. This is a simple intratesticular cyst. This is opposed to this case, where a patient feels a scrotal lump. Here's our testicle, not homogeneous. We can make out the margins here of this intratesticular lesion. Next question, solid or cystic? Well, this looks like it has meat to it, as opposed to our anechoic cyst. This is a solid mass. This is cancer until proven otherwise. Patient gets an orchiectomy, and this is a seminoma. So solid intratesticular masses with internal vascularity represent testicular tumor until proven otherwise. We'll divide our tumors into seminomatous and non-seminomatous tumors. Seminomatous tumors will be much more common than the non-seminomatous tumors. In terms of tumor tipping points and what is going to mitigate the prognosis for the patient, we're looking for adenopathy. but we have to remember the embryology and subsequently the lymphatic drainage of the testes, that they are going to be following the para-aortic chain. As in this example, here's our aorta, big time para-aortic adenopathy originating from the testes. So testicular tumors, we can separate into germ cell and sex cord stromal tumors. Again, our big distinction at this point is seminomatous from non-seminomatous. Again, seminomas will make up the majority. And then we have our miscellaneous lymphoma, especially if they're moldable lesions, older patients. So this is another scrotal lump. You see the lesion is in the testicle, as opposed to the other case. This one is much more heterogeneous. We have solid components, but we also have cystic components. So a mixed solid and cystic lesion. This was a embryonal cell carcinoma, a non-seminomatous testicular cancer. So some fake outs to be aware of. Here we have the testicle. There's a lesion inside the testicle. It's an intratesticular lesion trying to decide solid or cystic. This looks like it has some meat to it, but also some low echo areas. So, is that necrosis? Is this a tumor with necrosis? That's what we thought. And the interesting thing is there's lots of blood flow around the lesion, but not so much inside the lesion. And this ended up being an abscess. So this can be potentially a fake out or tumor. So a patient with acute pain, we need to be thinking torsion or infection. So this is a patient with left-sided pain. Which side's abnormal? I like this view where you see the right testicle and the left testicle, and there's asymmetry. There's blood flow here, no blood flow there. So we have to decide, is that too much and that's too little? Or this is just normal and that's too little? Or is this too much? So that's the differentiation we have to make. So this is normal blood flow to the right testes. This is normal, no blood flow to the left testicle. This is a torsion that they were able to detorse in the OR, pinked up, and salvage the testicle. So again, making a quick, accurate diagnosis is very important. Now, how about this case where there is right-sided pain? So we get the testicle, and then above the testicle, the epididymis, which is enlarged and a little bit hyperemic. And we focus on the epididymis, and we show it's very hyperemic. This is a case of epididymitis. So the involved side is usually enlarged and hypervascular. A trauma patient. This was a third base coach who was hit by a foul ball. Which testicle is abnormal? We have the right testicle above, left testicle below. Give you guys a couple of seconds to think about this. The right testicle, we can draw a nice circle around it. Looks nice and uniform, and there's good blood flow, and this is a normal amount. Left testicle, hard to draw a circle around it. It looks amorphous, and there's no blood flow to it. So this was a fractured testicle, which could not be salvaged. So testicular pathology. Remember the ultrasound workup. You have a lesion. Is it intra or extratesticular? Is it solid or cystic? Single or moldable? And is there a flow? Remembering that a solid intratesticular lesion is tumor until proven otherwise.